Okay. Okay, welcome back to the next session. If people could try and get to their seats so we can make a prompt start, if that's all right. So this session is very much related to ultrasound. I'd like to, if people could settle down, that'd be great. Thank you very much. First speaker of the session is Jeroen Kaijser, who is being truly heroic, having defended his PhD yesterday successfully. So congratulations, Jeroen. That's fantastic. That's fine. You can go off now. That's as good as it gets. So clearly, if he celebrated his PhD properly, he should have a disgusting hangover today. So if he hasn't, it's rather disappointing. Obviously, these days, everything comes down to evidence-based medicine, and so Jeroen did a lot of work doing a meta-analysis and systematic review of the current state of play with regard to how we can classify ovarian pathology, and that's what Jeroen is going to discuss with us today. Jeroen, thanks very much.
Yeah, thank you. Thank you, Tom, for these nice words. To find the answer to this very specific question has actually been the core aim of my PhD within the IOTA study framework. And I think we found the answer to that by doing a systematic review and meta-analysis, and I successfully indeed defended my thesis yesterday, where I already explained the answer to the question, but I will rehearse a little bit. A correct differentiation between cancer and benign conditions in women with adnexal tumors is of paramount importance to optimize further decisions on patient management, because patient outcomes in those being correctly classified with cancer have shown to clearly benefit from centralized care within oncology centers, whereas for benign ovarian masses, even expectant management or maybe minimal access surgery may be warranted with reduced costs, also morbidity, and also providing the ability to do something on fertility sparing options for young women. There are some key steps which are necessary to concentrate such care for ovarian cancer, and these include the use of solid evidence-based algorithms, preferably with a high sensitivity for cancer as a default situation. And furthermore, there should be well-structured cancer pathways, and also accessibility of care is quite important. But unfortunately, we still see that the majority of patients with ovarian cancer are not being treated by those specialists. Many population-based studies have shown that, and also a recent survey on specialist surgery for ovarian cancer in England, which has been published at the end of March, also demonstrated these findings. And there's actually an abundance of diagnostic algorithms available with all kinds of modeling techniques that either use morphological ultrasound features or Doppler variables, biomarkers, clinical characteristics that are continuously being developed, modified, evaluated and compared in different clinical environments and different populations. And of course the ultimate aim of these models is to place less reliance on the subjective impression of expert sonographers, which appear to be the best diagnostic test. But which one should we choose of these ones to improve the centralized care for ovarian cancer? Let's look at some influential guidelines, for instance by the National Institute for Health and Care Excellence or the SIGN or Royal College guidelines. And actually these guidelines still recommend the use of the risk of malignancy index, which was made 25 years ago by Ian Jacobs, which is a simple algorithm which uses CA125, menopausal status, and a few ultrasound features to classify patients at high or low risk of having ovarian cancer. But there were certain limitations to these guidelines because they mainly used the evidence from systematic reviews, which incorporated only diagnostic accuracy studies of models up until 2009. So it could well be that this risk of malignancy index, which is still recommended in many guidelines, has reached its sell-by date. Whereas There are many novel developments in diagnostic tests for this characterization of adnexal masses, many new promising tests. For instance, the risk of ovarian malignancy algorithm, which is a new commercial biomarker-based algorithm which uses CO125 and HE4 together with menopausal status. And of course, there are the main ultrasound-based strategies by the International Ovarian Tumor Analysis Study. And all those have not been critically appraised. Let's just go over the two main IOTA models. The first approach uses risk models. This is the simplest one, using 6 variables, including age and 5 ultrasound features, of which the red ones here are predictive of a malignant tumor, and the green one is predictive of a benign tumor. And this model provides you accurate risks and absolute risks of a patient having ovarian cancer. You can use it in all tumors. You can decide upon which cutoff level you use to indicate cancer, depending upon your preference or local setting. However, the downside is that you need a computer or a mobile app to use the model in clinical practice. The other approach with which IOTA made is our simple ultrasound-based features, which are based on virtually pathognomonic features of either a malignant tumor, these 5 features, or either a benign tumor. Those are these 5 features. And these rules can approximately be applied to 80% of all tumors. There are 2 ways to use the test for the other group. Either you can classify the 20% which cannot be classified by the simple rules as malignant, or otherwise, maybe preferably, you can use a 2-step procedure in which you use the subjective impression of experts to classify this residual group. That's actually the way how to use these simple rules. And they're quite intuitive and to clinicians to use, quite simple. So actually there was a real need to construct a new systematic review and meta-analysis to also incorporate the latest evidence on different models for preoperative diagnosis of ovarian cancer. And these systematic reviews and meta-analysis are quite important and influential for professional societies to make new guidelines. And we performed a new meta-analysis and published it in HR Update in 2014. In which we actually updated a previous systematic review and meta-analysis by Peggy Jomini, which was published in 2009. And we used the same methodology and search strategy as described in the original paper. We had a specific interest in prediction models that contained at least 2 variables, and that had been externally validated in at least 2 studies on a combined minimum of 1,000 adnexal masses at least. Preferably in the meta-analysis, we used center-specific data from included multi-center studies. And we focused on pooled sensitivity and specificity at the original proposed cutoff level of the prediction model as the main outcome of our meta-analysis. This is the Prisma flow diagram. It's a busy slide, but we searched up until October 2013. And in total, we included 195 studies in the systematic review, which reviewed 116 different prediction models. And actually, only 19 models met our predefined criteria for the meta-analysis. So 2 external validation studies on a minimum of 1,000 masses. And they have been validated by 96 studies on a total of 26,000 adnexal tumors. And here you see the different prediction models which we included in the meta-analysis. They contained morphological scores, mainly from the past. The different variants of the RMI model. We contain different logistic regression models. These are the commercial biomarker-based algorithms. We had the simple ultrasound-based rules, and we also included artificial neural networks. And of those 90 models, in this rock plot, you can see in the upper left corner that the IOTA approaches outperform the other included models in the meta-analysis. And in the green box over there, you see the RMI variants 1, 2, 3, and 4. Let's have a closer look at these results. The simple rules, when used as a one-stop strategy, classifying the inconclusive cases as malignant, had been validated in 5 studies in 17 centers and reached a sensitivity of 93% and 81% specificity. The LR2 model had been validated in 3 studies in 13 centers and reached a sensitivity of 92% and specificity of 83%, whereas the RMI1 is the most validated model of all included models that have been validated in 41 centers and reached a sensitivity and specificity of 72 and 92%. Here you can see the distribution of the center-specific results of the IOTA models and the most validated models. And let's have a closer look at the level of expertise of the examiners which validated the IOTA models. As you can see, it has been validated in 5 studies, of which 3 had been conducted in less experienced hands. This study by Timmerman et al. Was in experience level 3 examiners, and the study by Fatale was not clearly defined what the level of expertise was by the examiners. And in the IOTA LR2 model, there were 2 studies in less experienced hands and 1 in expert examiners. And if we look at this forest plot, in blue you see the results per center in experts with their results of sensitivity and specificity. In yellow you see the results for the non-experienced hands, and here in, well, I don't know what the color is, you see the study by Fatale, which is in undefined cases, and you can actually see that also in less experienced hands the results are quite comparable to those being achieved in experts. And the same accounts for the IOTA LR2 model, where we specifically look at each center. You can see that the sensitivity and specificity quite holds up when you compare them to the experts in the centers in the IOTA study. We were also interested to look at the test performance in pre- and postmenopausal women. However, it was not feasible to do that for all the models included in the meta-analysis, because most studies did not provide those post-hoc analysis in their original papers. But we could do so for these 3 models by using the combined data sets of IOTA phase 2 in experts and IOTA phase 4 in non-expert hands. And here you see the individual results per center for premenopausal women, and you see clear differences, mainly in sensitivity. The IOTA models had high sensitivities in premenopausal women, whereas the RMI using it in premenopausal women only reached 40% sensitivity. And when we did so in postmenopausal women, well, you could see when looking at all the centers that the differences were much smaller, but still the IOTA approaches, when using the proposed cutoffs, still has a higher sensitivity than using the RMI. Let's have a closer look at the quality, because that's also important. You can use a quality assessment tool, QUADAS-1, to assess the quality of diagnostic accuracy studies included in meta-analysis on diagnostic tests. And when we specifically looked at the LR2 and simple rules model, we saw that most were prospective large studies with adequate blinding procedures and consecutive data sampling, and those are important quality measures. However, when we looked at the RMI-1 validation studies, there were some concerns regarding study design and also the quality of reporting of those studies, because we saw that 11 of the 23 studies included in the meta-analysis were retrospective. 2/3 of them did not report any blinding for final histology, and that could really over-optimize your results. And also 7 of the 11 retrospective studies did not report whether consecutive sampling was adopted, and most did also not report a time interval between index test and surgery. So there were some concerns regarding quality of the RMI validation studies. So based on the evidence included in this systematic review and meta-analysis, we concluded that an evidence-based approach for the preoperative characterization of an adnexal mass should either include IOTA LR2 or the simple rules. And the findings were based on high-quality evidence when applying the QUADAS-1 criteria. We saw previously that there were reassuring results for both IOTA approaches in non-expert or less experienced hands. And we saw a higher sensitivity for the IOTA models compared to RMI when using the proposed cutoffs in both pre- and postmenopausal women. Only very recently, we just finished a new meta-analysis together with the group of Maastricht from the Netherlands, in which we had a specific interest to look at the subjective assessment of grayscale and color Doppler ultrasound findings compared to the IOTA LR2 model, simple rules, and RMI for the preoperative diagnosis of ovarian cancer. And we registered the protocol at Prospero, which you can see over there. We did our last search at the end of July in 2014. And we included 42 studies, which included 18,000 different masses. Let's have a closer look regarding the IOTA approaches. We now included 7 studies, of which 2, the study by Tanti Palancoren and Nunes, were new as compared to our previous meta-analysis. Those 4 were in the non-expert hands, experts, and undefined experience level of the operator. For the LR2 model, we still had 3 studies, but the study of Nunes was an extended study which contained more patients as the one we had included in our meta-analysis. These were the results for both. We looked at both strategies, either when the inconclusive cases were classified by subjective impression, or when the simple rules were used in a way that we classified inconclusive cases as malignant. We also looked how good simple rules was as a triage test when they could be used in the group of tumors, and then they reached a sensitivity and specificity of almost 90% and 96%, so that's very good. These were the results for IOTA LR2. And then we have the overview rock plot and all methods on the investigation, which you can see over there. So we have the simple rules with subjective assessment, the subjective assessment of all masses, the LR2 model, and we have here the other strategy of simple rules when classifying inconclusive cases malignant. And all methods on the investigation yield better test performance as compared to the RMI variants over there. And actually what we saw was that when using the simple rules with classifying the inconclusive cases with subjective impression, preferably by an expert, yielded actually best test performance and actually also matched the results of subjective impression by experts. Here is the overview. So for subjective assessment, 22 studies were included and they reached a pooled sensitivity of 93% and almost 90% specificity. Here you can see the results for both simple rule strategies and for the LR2 model. And here are the ones for the RMI models. So actually, the study by Meijs et al. Concluded this was the first review that addressed subjective assessment and compares it with other frequently validated models for the classification of adnexal tumors. And all methods, what I said previously, yielded better and superior test accuracy when compared to the currently used RMI. A two-step strategy of simple rules with subjective impression for inconclusive tumors yielded best results and matched the test performance of expert ultrasound examiners. And the LR2 model could be used as an alternative if such expertise is not available. So to finally conclude, how should we triage our women with adnexal tumors that require surgery this year based upon the evidence from these 2 meta-analyses? I think after a critical appraisal of all the available literature, I think we should include IOTA LR2 and simple rules in our protocols for the preoperative diagnosis of ovarian cancer whenever the subjective assessment of an expert sonographer is not available. And probably in the future, the IOTA next model can supersede the IOTA LR2 model. But first, external validation is necessary, and Ben van Galster will tell you all about it in the next talk. And of course, when we look at the simple rules, there are still 2 downsides, because preferably you would use it in all tumors, and maybe also you want risks that you can discuss with your patient, and it doesn't provide you those things. So the IOTA study is currently also looking at developing a new risk score, which is based on the 10 ultrasound features of the conventional simple rules, and see whether this risk model can provide risks to all patients and thus can classify all tumors as such, and also provide accurate risks. So that's something for the future. To facilitate the use of the IOTA approaches in clinical practice, there have been several apps now available, for instance, for the use of the risk models and simple rules. And very recently, there's also the IOTA Adnex app available to use those models in clinical practice. I think the use of IOTA models will improve the existing management and guidance and triage of patients with adnexal tumors for subspecialist care. If we would do so, and we would use them and compare it to RMI, for instance, in Belgium and the Netherlands, you would, per year, you could correctly diagnose 160 and 250 patients respectively each year when you would use the IOTA approach as compared to RMI. So as such, that would prevent many secondary surgical staging procedures in false negative cases, and will also likely have a positive influence on the long-term prognosis in those patients with cancer. So currently there is no need for women at high risk of having ovarian cancer not to have surgery performed by the right surgeon in the right place and at the right time. And I think as a final remark, it is to be hoped that at least the evidence-based guidelines by professional societies on management of women with suspected ovarian cancer will become updated to reflect the improvements in the preoperative diagnosis as shown in the meta-analysis of the past few years. Thank you very much.
Jeroen, thank you. We're going to have the lights up. Any questions? I think we've had one question from the floor so far today. I think we're going to have to end up randomly putting the microphone in front of people soon. I mean, the issue is this resistance, isn't it? I mean, how long it takes to take from doing research, publication, and so on, actually into clinical practice and eliciting change. It's really difficult. It was kind of brought up in your Viva yesterday, I thought, well, it was brought up, shall we say. Why do you think, I mean, this whole thing comes up where people say, well, it's very difficult. IOTA ultrasound variables are difficult. And it always strikes me that people forget that the RMI has actually got ultrasound variables, some of which are never actually looked at, because the presence or absence of metastasis is very difficult to do. Do you want to comment on this, sort of the relative ease of the variables which are now being used in IOTA models versus, for example, RMI? Because I personally just don't see it.
Well, I think there is a sort of training necessary, to me at least, before you can adopt those models into clinical practice. And that's maybe what people don't like, that they have to learn something new, of which they are used to, compared to what they are used to already for 25 years. But I think the results stand up as they are, and we have to move forward. But it's difficult, yeah, to incorporate them in clinical practice.
Do you think someone might criticize the group for doing a systematic review and meta-analysis where so much of that analysis, of the new information put into it, is actually from the IOTA group? I just wondered if you have a view on that. You don't have a view?
Oh, well, it was discussed yesterday as well, wasn't it?
Yeah, but not everyone here was at your thesis.
Sorry.
It might have seemed like 300 people in your exam, but there wasn't 300 people.
Well, you mean that the criticism is that we conducted the review ourselves, in which we evaluated our own models? In that sense, we could be a little bit biased, or...
Well, the whole point of doing these reviews is I don't think they should be biased, because it's actually using, hopefully relatively non-subjective ways of assessing the evidence. I think that's the point I was kind of trying to bring out. I think it's, the whole point of these, if you're going to use this type of review as the highest level of evidence, then the quality criteria and so on have to be applicable in a way that don't introduce bias. That's the whole point, I think, really. Final question, sorry to do this to you because you're feeling a bit jaded after yesterday, is this: how do you handle multi-centered data within the context of a systematic review? I think it's a difficult one because, if you look at Caroline's paper, I think it was based on about 997 patients from 12 centers, and yet it goes in as one study, but actually it's not.
Yes, I had before we conducted the next meta-analysis, we had a discussion with the statisticians from the Center of Evidence-Based Medicine here in Leuven. And we had a long discussion about whether we should do the same strategy again by including center-specific results. But they actually said to us that it's not necessary when using a multi-center study within the framework of a meta-analysis. You can also use the pooled results. So they said to us that from their statistician point of view, it was not needed to stratify results and use it as individual centers within the context of a meta-analysis. At least not what we have done previously in our meta-analysis. That's what they said to us, but I'm not...
Well, I won't labour the point because it's quite statistical. I think Dirk Tillerman wants to make a point, is that right? No? You put your finger up. You wouldn't be very good at an auction, would you? You'd end up buying a painting and you wouldn't even know about it.
Dirk?
Question where? Usha Menon, sorry.
the easiest way to change guidelines would be to get NICE approval. And I think, so going forwards, you need to do some kind of a prospective, interventional, randomized trial, if possible, or at least a prospective trial, do health economics. Because, finally, whatever model we use, we don't only use it. We use the model, plus some various subjective things that happen. So in real life, it is not just the model that will be used. And so to know exactly what the model adds, or in terms of savings, in terms of what happens to these patients, you need to comment on complications, you need to, when you operate on these women. All of this could be so well done, because I think you've done such a lot of good work. Now there's just that one step, and then you would get very
that's
wide
what we plan to do
acceptance.
within the IOTA framework as well. Yeah.
Yes.
I think it is this year, isn't it, that the NICE guidelines will be changed, or isn't it?
No, there's no plans to revise it.
I'm not sure there's plans to change that. Is there another question, sorry? Bear?
So I think you underestimate the challenges. I mean, within rockets, even within a research setting, I'm Sudha Sundar, I'm from Birmingham. I think you underestimate the challenges that practically exist in changing an ultrasound scoring system. As you know, I'm not an imaging person, and even within the context of a research study, the actual logistics of training up people, making sure it's amplified, making sure these things are scored, written down, and then acted upon, actually changing the whole process is far more complicated, because at least in the UK, it's an NHS change implementation project, rather than just a question of the individual person changing how they score things. So I think it's important to not underestimate the challenges here.
I think that's a logistical problem. I think that, for example, when we did the IOTA 4 study, literally our training for the sonographers was one morning of theoretical training, and their results were as good as the experts have done before. So I think if the willingness is there, I don't think it's an issue of getting people to accurately do this. I think there's a lot of, in the UK, so this is an international meeting, UK is so conservative with ultrasound, it's been one of the slowest countries in the world to take it up and actually use it properly, that it's, it's very, very, very backward, frankly. It's. I don't think the same applies to an international audience, where I think uptake of these things is much faster. So I don't think we should get too fixated on that discussion. Jeroen, fantastic. Thank you very much. Go and lie down. And once again, congratulations.